We'll now move to our next presentation, that is the case in box by Dr. Preeti Sharma from Max Hospital, Dehradun. While we solve that, we'll move to our next presentation by Dr. David Rozario, ROTA cut, the cutting edge for calcium treatment.
Thank you so much to the organizers for giving me this opportunity. It's really a pleasure and a deep honor for me to present today. Can I have my slides? Right. So my topic is the ROTA cut, that is a combination of rotational academy and cutting balloon in calcified lesions. The concept is basically that if one does rotational academy followed by using cutting balloon, one may actually get a larger lumen gain compared to just using rotational academy followed by a conventional non-compliant balloon. So that's the concept. Whether it works or not needs to be seen. So I will just like to go through a few studies. There are not a lot of studies, but there are some studies where this ROTA cut strategy actually has been used. And probably the latest one of them is from Mount Sinai, Dr. Shamin Sharma et al., where they actually used rotational atherectomy with cutting balloon in moderate to severe calcified lesions versus rotational atherectomy followed by non-compliant balloons. So this is what they did, and the endpoints were actually validated by IVUS, and the final IVUS image was actually images were blinded to the primary operator. So what it was found was that combining rotational atherectomy with cutting balloon actually gave a similar minimum stent area. The MSA between the rotational atherectomy and the cutting balloon group was similar to the rotational atherectomy with a non-compliant balloon. However, there are a few points that needs to be taken into account. One is when the FDA actually approved this trial, what they said was you cannot go with a cutting balloon to more than 12 atmospheres pressure, because prior to this study there was no FDA approval for the use of cutting balloon in severe calcified lesions. So they said you may use it in this trial but not more than 12. So that is what actually Antonio Colombo pointed out, that perhaps had they gone to higher pressures the results would have been different. Softer endpoints like there were more cracks actually. I was shown there were more cracks in the rotational atherectomy with the cutting balloon than the rotational atherectomy with the non-compliant balloon. The stent expansion, which is actually the MSA divided by the mean of the proximal and distal reference diameters, areas, that actually the stent expansion actually was better with the rotational atherectomy and the cutting balloon compared to the other group. However, these were the secondary endpoints. The primary endpoint of MSA was not, and perhaps because of the lower pressures with the cutting balloon. So then this is a prepared trial, slightly older compared to the ROTA cut trial of Shamin Sharma. This actually is from Europe, where actually they have compared rotational atherectomy with cutting balloon and they have compared it with a modified balloon. And they found actually that the results are that you do get higher acute lumen gain and higher MSA compared with the ROTA cut strategy, and it's a safe and feasible strategy. Then this is actually a smaller study from China, where actually they have actually compared the same thing, rotational atherectomy with cutting balloon and versus rotational atherectomy with a normal non-compliant balloon, and where again they found that same thing. The results were that aggressive plaque modification can be safe and is feasible, and it does actually translate into better lumen area when you use the rotational atherectomy with the cutting balloon strategy compared with the rotational atherectomy with the non-compliant balloon. So, and this is another trial which actually shows a similar thing, where you get more fractures, better lumen gain when you use rotational atherectomy with the cutting balloon versus rotational atherectomy with the non-compliant balloon. So what we basically do is, now does it mean that I use cutting balloon in all patients when I do rotational atherectomy? Obviously the answer is no. So what we do is we rotablate, and once we've done the rotablation, we keep the rota wire in place and we put a workhorse wire parallel to the rota wire, and then we take a non-compliant balloon which is 1:1, and the 1:1 balloon actually has fully expanded at around 14 to 16 atmospheres pressure in two orthogonal views, which means that I actually am done and I can put a stent. Whereas if the non-compliant balloon has not expanded in two orthogonal views at 14 to 16 atmospheres pressures, it means that I'm not done and I either need to upsize the burr at the rotor wire parallel, so I can upsize the burr, or I can use a cutting balloon to get the job done. So that being said, I'll just show you one or two cases, I think, where we have done this strategy. So this is a 65-year-old gentleman who had come to us, who was a hypertensive and had undergone CABG 10 years ago and had presented with efferent angina class 2, which had come to class 3. And he had undergone Lima to the LAD, saphenous vein grafts or diagonal, ramus intermedius, OM of LCX and PD of RCA. ECG showed Q waves inferiorly, and there was inferior wall akinesia with an EF of 40% on echo. Now, this is the angiography which was done in an outside hospital, and what it basically shows that surprisingly the Lima to the LAD was occluded, and the SVG to the PD of RCA and ramus intermedius were occluded as well, and the SVG to the diagonal branch was patent. So this is actually almost like a single surviving artery. And we have you can see there's a very tight, heavily calcific distal left vein stenosis. There's a very sharp angulation from the left vein to the LAD, which is also heavily calcified and critically stenosed. So this is what we are working with. And so this is how it looks. So what we did was we actually wired this vessel with a workhorse wire, and then we extend a rotor wire. In the second screen, picture you can see we are doing a rotation with a small burr. It's a 1.25 mm burr. It's a little difficult, and then finally it does make the pass, and this is the final polishing run. And this is how it looks after the 1.25 burr has done the job. And after that we knew 1.25 burr was not enough, so we've taken a 1.75 burr, and this again is finding a little bit of trouble to go in, as you can see, but it actually finally does make way. And you can see that it actually has passed. And this is how the picture looks after the 1.25 and the 1.75 burr has done their job. So then what we did was we took a 1:1 non-compliant balloon, which is a 3 mm balloon, and you see there's a waste there. And so we know that we're not done. And though we have used 2 burrs, there's a waste in the 1:1 non-compliant balloon. And so we knew we had to do something more. So we actually have taken a cutting balloon here. And the center picture actually shows a cutting balloon, which shows good result. We did a cutting balloon along the entire length of the artery, left into LAD. And the picture on the extreme right shows that the results actually look quite good. So when we have this kind of picture, we know that we are good to stent, and so we put overlapping drug-eluting stents from the DES from the left vein to the LAD, and you can see that the end results look quite good. This patient has been asymptomatic for quite some time now, and he recently also came for a checkup. He's doing good. So this is one case where we had. This is a second case. This gentleman actually was a high bleeding risk patient and actually came with efferent angina class 3, and as you can see, heavily calcified, distal left main, very tight, osteoproximal circumflex calcified, osteoproximal LAD is even tighter. The osteoproximal LAD is heavily calcified and very, very tight. He had a absorbed BVS implanted previously to the LAD and a metallic DS to the LCX previously previously. So this is the iliocaudal view, which shows the calcium, the left main disease, the calcific, very tight LAD stenosis, the very calcific LCX stenosis also can be appreciated, and this is the epicranial view. So what we did, basically did in this case was we wired with a workhorse wire, and we started doing rotational atherectomy with a 1.25 mm burr, with a 1.75 mm burr, I'm sorry. As you can see, the 1.75 burr is not crossing, and we've been at it for a while now. The guide catheter is coming out, the burr is not advancing forwards, so we know that the 1.75 is not crossing the lesion. So what we did was we downsized to 1.25 mm burr. Here also you can see the guide catheter is coming back, so the 1.25 mm burr is also finding it difficult to cross the lesion. So what we did was we upsized, kept at it, and the 1.25 mm burr was finally able to cross the lesion, as you can see. Once we've done that, this is the picture of the 1.25 mm burr. The results looks better than before. And since we had already opened the 1.75 mm burr on the table, we took the 1.75 mm burr and did ablation. As you can see, the 1.75 mm burr nicely crosses the lesion and has done the job. And this is a picture after the rotational atherectomy with the 1.25 and the 1.75 mm burrs. So, and this is a picture in the ROTA caudal view. It looks better, but the job is not done. So after this, what we do is we wired both the vessels with the workhorse wires, And we took a cutting balloon this time, and we did a cutting balloon angioplasty left main to LAD. As you can see, the cutting balloon is positioned. The cutting balloon has nicely expanded to the left main to LAD, and this is how it looks. Now the LED looks really good. So we have seen this time and time again. If you do rotational anatomy with a cutting balloon, you do get very good results. And then we did the same cutting balloon to the circumflex, nicely expanded, and this is how it looks. Now both arms look expanded. You can see there's a dissection on the left main to LAD on the superior margin, so we know the vessel is well prepared. We knew we would put a 3.5 mm stent in the left main to LAD, so we took a 3.5 mm non-compliant balloon just to make sure it is expanding well. And at 14 atmospheres, it is well expanded, so we know that we are now good to stent this. So I'll just skip the steps. What we did was what we usually do in our center is we do a step mini crush. We first position a stent in the side branch. We have a balloon in the main branch getting ready to crush the stent. We optimally position the stent and we expand the stent. As you can see, that stent in the LCX is nicely expanded at around 14 atmospheres pressures. And after that, we've taken a picture. This is, I think, is a very important step when you do either DK crush or mini crush. You take a picture after you implant the side branch stent, and if there's an issue downstream, you need to fix that first before you crush the stent with the balloon. So then the main vessel stent came in, and the main stent was deployed nicely, as you can see, at around 12 to 14 atmospheres pressures. We did a port. After that, crossing with the workhorse wire was very easy. Just a workhorse wire. Then we did a sequential high pressure dilatation of each arm, and the final kissing balloon at around 14 atmospheres pressure. And this was the final results. So just want to illustrate a few cases that where we have used this combination of rotational anatomy. This was image guided, and we do get very good lumen area at the end of rotational anatomy with cutting balloon. Doesn't mean that you need to use rotational cutting balloon in all cases of rotational anatomy, but if your imaging shows that there is not enough cuts, or you find that the non-compliant balloon 1:1 is not expanding, then you should upgrade to either you can increase the burr size or you can increase the cutting balloon. Upgrading to a burr may be difficult, because if you want to use the bigger size burrs like the 2 mm burr, you require a definite 7 French. 2.15 will go to an 8 French. Also, if you're using the Y connector, the normal Y connector that we use for angioplasty, that takes the 1.25 and 1.5 burr. But the 1.75, you need the screwing micro connector, otherwise it tends to get trapped at times. That's what you find. So that's my presentation.
Thank you, Dr. David, for a very lucid presentation and excellent demonstration of the ROTA cut technology. A couple of things which I wanted to ask you. One is, for the interest of the audience, I would like you to just elucidate how do you size your cutting balloons according to the lesions? Yes. So what size do you use in a normal vessel? What size do you use in an ISR? So how do you size your cutting balloon?
So in a normal vessel de novo where there's no ISR, what I usually do is I take a quarter size down, but a one size down. So one size down is always not all possible. Like for a 3.5 mm vessel, I would like to use a 3.25, but we don't usually get a 3.25 cutting balloon. For a 3, I will use a 2.75. For a 4 mm, I would like to use 3.75, but that's not easily available, so we'll go with a 3.5. So with a de novo lesion, I like to keep one size down. And with a Wolverine cutting balloon, we can actually go to higher pressures. So I go to around 16 to 18, up to 20 atmospheres also for de novo lesion, not a problem. With the older flextome, there was a problem. If you go beyond 12 with the flextome sometimes used to rupture. But I have not had any instance of rupture with a cutting balloon, with a Wolverine cutting balloon at 18 to 20 atmospheres pressures. For an ISR lesion, I will definitely go 1:1 and go to around 20 atmospheres again. You inflate the cutting balloon, keep it inflated for 30 seconds to 1 minute, so you get deep cuts, and then you deflate the balloon, pull it back, rotate and push it forwards, so that your atherotomes are now oriented along different planes. The cutting balloons actually have got 3 atherotomes up to the 3.25 cutting balloon. The 3.5, 3.75 and the 4 actually have 4 atherotomes. And these atherotomes are actually 5 times sharper than a surgical scalpel, people who have done bend studies. So this is how we use the cutting balloon.
So that's a very interesting point which I wanted to bring around, and Dr. David has elucidated it beautifully, how we can reintroduce it, change the alignment and get more cuts. Now, one last question to you. You used a 1.25 burr, you upgraded to a 1.75 burr, and then you used a cutting balloon. Could all of this have been avoided by just going in with an orbital atherectomy?
When we had done this case, orbital atherectomy, the case that I showed, this was done in actually 2021. So
So
orbital
it was not
atherectomy, we
available
don't
at
have
that
orbital
time.
atherectomy at that time. And so we took a 1.25. So when I upsize a burr, I usually go from 1.25 to 1. We upsize by 0.5. So if I've taken a 1.25 burr, if I have to upsize, it will be 1.75. And now coming to rotational atherectomy, the orbital atherectomy, I will say in most cases you can do either rotational atherectomy or orbital atherectomy, whichever one you would like to use. The advantage of, of an orbital atherectomy over rotational atherectomy is through a 6 French with the same burr, with a lower speed of 80,000, you get a burr area equivalent to a 1.5 burr. And if you go to the highest speed of 1,20,000 RPM, you get an area equivalent to 1.75 burr.
So that's the point that I wanted to bring about. Single burr, 6 French size, you can treat all vessels 2.5 to 4.
But that being said, I have to say, I have seen some very proficient US operators who are proficient with both. And what they have said is, with the higher speeds of 1,20,000 orbital activity, you do definitely get higher incidence of perforations, slow flow, and dissections. I've seen it. And so in most cases, I will say you can use rotational activity or orbital activity equally, but there are some cases rotational activity is the preferred treatment. For example, if rotational activity, because it's got a forward cutting mechanism, if you have a very tight stenosis where you have difficulty in passing with a microcatheter, rotational activity because of its forward cutting mechanism will be better. In aorta ostial lesions, rotational activity will be preferred to orbital activity. One could say that you can ablate on the way back. That is true if, of course, your stenosis is not very tight and not very long. So if you are not able to push the burr, the orbital burr forwards to do the backward cut, then in aorta ostial lesion you're in trouble. Orbitectomy is rotationectomy is the way to go in angulated lesions for mainly two reasons. One is the orbitectomy wire is a 012 wire, so it will give you more bias compared to the 009 wire of the rotationectomy, number one. Number two is by virtue of how it cuts, because of its forward cutting mechanism versus the orbital movement of the orbital atherectomy in angulated lesions. If you are planning to do atherectomy in angulated lesions, I'll tell you rotational atherectomy will be safer. And in stents, if you are going to ablate a stents, rotational atherectomy is a safer way to do, because I have seen some very good US operators, they have actually ablated the stent. Actually, the whole stent has come out with orbital atherectomy. So there's no problem.
So very interesting point said. What is very important and important to note that the technology has to be used in the proper way. So if we are going to use orbital at a high speed, every time that you orbit, you have to take a puff and see if there's any dissection, because the mechanism different. It moves in a circular way. And if it moves in a circular way, it will find the dissection and it will create a perforation. So in the presence of dissection, do not orbit. That is the dictum, and that is why all the perforations have occurred. So check after every orbital run that you have taken whether there's a dissection or not. You find a dissection, stop. That's your end point. Second, forward cutting and backward cutting mechanisms are both there, which makes that ostial lesions, you can always do a backward cutting, which gives us an advantage. Less incidences of a stuck burr occurring in those situations. Thirdly, when we talk about wire bias is very important, because in rotational atherectomy, we have a forward and backward movement. But in orbital atherectomy, the crown is placed in an eccentric manner. And when it's placed in an eccentric manner and it's moving centrifugally, it's moving round and round, not forward and backward, the wire bias becomes less. You tend to hit all sides of the wall. So those are very interesting differences. All technology is beautiful. All technology should be used beautifully. Thank you so much for a lovely presentation. One last question, please.
Just then, which you use rotatripsy for?
That's a good question. I think the rotatripsy is the, if you have a, if you want to ask me about where, now, if an operator is proficient with rotational atherectomy, orbital atherectomy, and let's say, and IVL, I will say I will probably prefer to use IVL. See, IVL is the safest of the three and the easiest to do. There's no doubt about that. So I will say if you have a large vessel 3.5 and above, you have an proximal lesion, easy access, the IVL balloon will go straight, you do a IVL and you can come out. If you have more diffuse angular tortuous lesions where your IVL balloon is not going to take a turn, that is where there are two things you can do. The safer way is to do a rotation anatomy with a small burr, make a passage, then you take an appropriately sized IVL after imaging and they do a rotatripsy. That is easier to do because I have done, trust me, it is changing a burr, upsizing a burr is not easy, it's tough. And then again your guide catheter size matters also. So if you've already started with 6 French, you may not be able to upsize to a very big bird. That's another point.
Sir, do you still
so if
start
you
with
have
1.25 or 1.5 in a narrow vessel?
No, see, thing is, what size burr I will use, it does not actually, there are two things I will say here. If you have a very calcified lesion, I would prefer a burr to artery ratio 0.5 to 0.6, no doubt about that. That's what we'll do. However, let me tell you, if you find that you cross with a workhorse wire and you have difficulty in passing a microcatheter to do the exchange, you either have to screw the microcatheter or you have to use a screwable microcatheter like a Corsair Pro XS or Tonus. You start with a 1.25 mm burr. If your microcatheter goes smooth across, even if it's a tight lesion, if you have a normal wire, your microcatheter has gone smooth, you have exchanged for your wire, you do ROTA with a 1.5, no problem. But if your microcatheter is having problems in going across, you have to screw it in, or then in that case, I will say you take 1.25 or 1.5 will not go to just waste money and time.
So, thank you so much. And now very nice presentation. And we'll move to our